Welcome to PG Pulse, Press Ganey's podcast on all things healthcare, tech, and human experience. In this podcast, we'll be joined by some of the best and brightest minds in the industry to discuss challenges, share insights, and innovate the future of healthcare. Thanks for tuning in. We hope you enjoy the conversation.
Welcome to another issue of PG Pulse, a podcast where healthcare's leaders talk about innovations in connecting the human experience in healthcare. I'm thrilled to have my friend Katia Sokoloff joining us today. Katia leads patient and family experience at Children's National in Washington, D.C. And there is no better person in my mind who's had more influence on me on how we can really engage patients and families in the design of healthcare. I'm excited to have Katia share the story about how her team's developed, how she's really invested and organized and built structure to be able to bring patient and family voice into the design and delivery of care at Children's National. So, Katia, I want you to start talking about your amazing team.
Well, thank you, Chrissy. And honestly, right back at you. I love partnering with you. We've had a lot of fun together over the years. I'm so happy to talk about my team. Really, really proud of the Children's National team. We are a small but mighty team, as are many patient and family experience teams. And I know today we're really going to talk a lot about our advisory councils, and that team is even smaller. But we have a wonderful team of consultants who are really internal consultants. They work for Children's, they work for us, they partner with our families, a fantastic program manager, and then a manager of patient and family-centered care who really makes the stories come to life with our patients and families. And she's got two team members as well who keep things going, creating content, finding ways for patients and families to engage.
I think a lot of us think about the altruism of patient family advisory councils. We know philosophically they're a great idea. We know operationally they can bring value, but oftentimes that's sort of where the commitment is. It becomes an afterthought and maybe part of several people's jobs. You've designed two roles, and I think there's something to the story of the people in those roles and how those roles evolved. Would you mind kind of explaining to everyone listening what these roles are and where they came from? Because I think it's a pretty amazing story.
Yeah, well, these two folks are led by the fearless leader, Miss Darcel Jackson, who is well known and respected in this work nationally. And she and I have been working together since I got to Children's National, really thinking, how can we help get her some help? Thinking about how do we continue to grow this program. And after some partnership with the Institute for Patient and Family-Centered Care, also talking with our colleagues in the Press Ganey peer groups, really understanding that we needed some roles that were dedicated. We were able to make that happen in some partnership with some grant funding as well, to really recognize that the hospital needed these roles. Our team needed these roles to tell the stories and to really facilitate meaningful patient and family engagement the way that we want it to be.
So let's walk through your councils. I know this has been a year of transition, but if we go to like the original state, 1.0 or 2.0, how many councils do you have? How do you identify where you might need a council? Talk to us about your council structure.
Well, our councils were, I think, like many of our peers, were a bit siloed. And so originally when we would talk about our work, and Darcel was really leading the work, we were thinking of our one council, which is our system level PFAC council, which we've had at Children's National for over 14 years, really strong work there. And so that group has a tremendous amount of history and commitment. And we would see other groups start, and they struggled during COVID, those smaller groups that had their own administrative and operational oversight, they were challenged. Whereas we really were able to pivot in the system level group to virtual environment. And we've actually not gone back. We try quarterly because we love to get together. But allowing for that virtual option has led that system level group to continue. But the evolution of our system level group really dialing in the process of how do you stand up a PFAC, the team has developed a playbook. And when we've been able to help both sort of re-energize the groups that had struggled before, some of the specialty groups, your heart centers, your
cancer, asthma.
Exactly. Help get them back on track, and then even invite new groups and cohorts to start their own PFACs.
So what are principles that you can share on the podcast? I know that we have partners today who are right in the beginning stages of engaging patients and families. What are three rules from Children's National that could make everyone kind of ground their work in something that's going to make it successful long term?
Gosh, well, just three.
We'll start.
Of course,
we'll
start on three.
Yeah.
But really, what stands out to me, and look, I think it is important to understand what a PFAC's role is in the organization. It is not, although it can sometimes serve as a support group. It's a group that is there to help provide the lived experience of our patients and families, former patients, current patients, families, so that we make care better. So one of the most important things if people are starting to create a PFAC is to really get clear on what it is that is the work. The next is really, I think, to start thinking about some of that sort of business stuff. You're going to have an application process. What are you looking for? What are going to be your sources of patients? Are you going to walk around and talk to families, or are you going to maybe chat with some of the nurses and see if you have any families who really feel engaged? So those are some of the things that are in a playbook that you might not think of when you're starting.
So over the past few years, you've talked about the pandemic. You've talked about how some groups were able to thrive during the pandemic. You've talked about shifts to virtual engagement. Talk to me about how your and Darchelle's perspectives have adapted over this last 5 years.
Well, when I came to Children's National, it was already very established that our system level PFAC was virtual. And I think we were really excited to see the engagement and hours participation had increased by a lot over our past years. We track, like many folks do, sort of the annual participation in other meetings that our PFAC advisors participate in their roles. And we were able to double that in some cases. And I think, the trick there was that it wasn't just the PFAC meeting that went virtual. A lot of meetings went virtual. And that
operational meetings.
Operational meetings, exactly. So that facilitated the involvement of our family advisors in meetings that, might have been hard for them to make otherwise.
And for them to be the only virtual attendee if everyone else was there. And so if you think about some of those operational or strategic meetings that your advisors attend, in addition to your system meeting, what kind of places do you have advisors contributing?
So many. It's really incredible. From our ethics meetings, we're thinking about certain care teams. People can get very engaged in a specific care team. But then one of my favorites is our patient-facing technologies team, which is where we talk access and having the parent voice there to gut check, well, wait a minute, how many different phone numbers are going to be texting me? Those lived experiences has been really, really helpful.
So just for my own curiosity, having patients involved in design is often a push-pull. Sometimes we're pushing our operators to involve patients. Sometimes, hopefully, we start to feel that pull of the real value of having patients and families in our design sessions. How have you cultivated that at Children's National?
You know, it's an interesting challenge because of the virtual setting. Sometimes we have guests who join meetings and don't know that there's a parent on the line. Oh. So, you know, and not that anything bad happens, but maybe even to ask the right question of there being a parent there. So it's a constant, I think, in every meeting. And honestly, we can do better at in every meeting setting the stage that there's a parent advisor here whose job it is to be here, and they've been vetted through the processes, and we can talk openly about, you know, what's going on. In sort of setting things up for success, we work with committees that chair these meetings and really find the right fit. We ask advisors to volunteer for which type of committee they're passionate about, and we'll match them up with some of those administrative leaders and have them get connected that way, so that there is that, at the very least, the core members of an operational team know that there's a family member on, and typically it's not uncommon for someone to say, and we've got one of our PFAC members here, we'd love to get your thoughts.
As you think about where we come from, and I think Children's National, as many of our pediatric organizations, were perhaps the first to truly embrace that human-centered design principle of actually bringing the patient or the family into the delivery of care. As you think about where we've come from, what are some of the limitations of the way we've always done things as you're reinventing how you look forward to what you might do in the near future?
Well, what really comes to mind as something that Children's is exceptionally known for is the way that we engage families in family-centered grounds. And not only as...
Can you share with everyone on the line about please, what that looks like? I know it's something that we're both so passionate about.
So thinking about, you know, in a patient's inpatient stay, the kiddo is staying in the hospital, when the team is rounding the clinician, the nurse, any other folks that are visiting each room to talk about what's next or what's happened or what we're waiting for or looking for, we want to get those families involved, and the patient too, as the development is appropriate. You know, and one of the things that pre-COVID and for years Children's National was really, really stand out for was engaging advisors in coming in and coaching teams on how to do those really well. And as many in the hospital world post-COVID are struggling to get back to interdisciplinary rounds, family-centered rounds, we are looking to get back to bringing those advisors in and retraining. Also, the workforce has shifted.
Well, and I think the community's shifted.
Yeah.
The community's really shifted, and that's probably one of the most remarkable things about the program at Children's National, is how widely you've been able to attract advisors who have varied lived experiences, you know, whether that's their socioeconomic background, their identity groups, thinking about how we bring a representative community to really develop the strategy of the organization. I was lucky enough to come to a patient experience strategy session at Children's National, and I do that regularly. I think I've never had as many actual patients and families involved in that strategy session as I had at Children's National. And so it's not only that you're ensuring that diverse voices are heard, but that they actually know their voices matter. And, you know, this was a half-day session, and it was really a trust-affirming experience for me to be there with your family advisors who were given important, dedicated time not as an afterthought or not simply as a response, but really to set the stage for what the goals of the strategy session would be. It was really remarkable.
That was so much fun. And I'm pleased to say, that was such a great opportunity for family members to get engaged, advisory members to get engaged. And we recently have been having strategic organizational strategy meetings where our chief strategy officer invited members of our advisory council to a few sessions. And so again, I think the repeated commitment that Children's has made, whether it's strategy for a certain type of work or it's a global strategy, and we've got to think 10 years out, gut checking that with our family and our community is so important.
Do you have any tips? I talk to partners all over the country, and they aren't able to attract such representative advisors for whatever reasons in their communities. Sometimes there are whole segments of their community who perhaps aren't used to having a voice or don't expect their voice to be recognized. Do you have any tips for the folks listening around how we can make sure that everyone feels like they belong?
A couple of thoughts. I mean, we have the benefit of having been around for long enough that we have staff members who will say, you've got to contact Darcel Jackson and you've got to get on this PFAC.
So your teams are really good at making those connections.
There's that known element where we get referrals, and that is certainly a big piece of it, I think, being a known entity. The other piece about getting representation, I think we've gotten better at that over the last few years we started a global services PFAC, which was, I think, one of the only, and they won awards.
What is a global services PFAC?
Well, we have a global services team at Children's National that really helps facilitate the care with families that need to come internationally for their care. And they reached out, that team, and said, we struggle to survey these patients, right? They've gone back to
their lives,
time zone, another life, and we really want to engage with them about what we can do to make this care better. And so through a lot of meetings with that team, we really realized PFAC is the right way to go. And with their knowledge of some of those cultural norms and desires, and also, I think, partnering with the community groups that support some of these families, really able to come up with a structure that worked. And so that team has a PFAC. There's a global services PFAC.
With members from all over the globe?
Yeah, I think primarily there are certain countries that are primarily there. But it's been really great for that service line because they have a place where they can go and say, what ideas. And it's very localized to the service line that is the global services. So it can be very, not narrow in a bad way, but it can be very focused on what they're looking to improve. And that's been really great.
That's a genius idea. That you have just blown me away.
Well, that team came to us. I think that's the other benefit is we have people coming to us saying we want to start a PFAC. So
if I were to go to any of them, those who are pulling advisors into the work, what do you think they would tell me is the real value of having patients and families at their elbow as they start to think about improving care? Why go to the trouble? Why do they want them there? What do you think they would say the value is?
I think they recognize that the organization listens to the advisory council. And so sometimes they're hearing great ideas from families and say, a great way for you to get that idea heard is to be in this forum. So I do think it's a recognition of the visibility of PFAC that people say, if you want someone to hear you, go work with that team. We've sort of enabled that by creating the PFAC seal of approval, which is a process developed, I think 2 years ago now, whereby if a project or an initiative or a review, it could be a built environment, furniture, it could be a building, comes before the advisory council, the system level advisory council, and meets certain patient family-centered care principles, it's voted on by that group, and it can receive a seal. And that is, we're trying to make a very big deal. You really want the seal, so try to pull in that engagement early and often. But I think some of those things, when the staff member is thinking, how can I help this parent's great idea come to life? They might be thinking that this is a great way to do that because we're going to help support that.
So we've talked about how you've supported the PFACs, how you build a structure for it. We've talked about the energy across Children's National to draw advisors into operations and strategy. Let's do a quick comment on how your senior team empowers PFACs. Is there any shout out you would have for other chief executive officers or operating officers, lessons that they could garner from your senior team in how to promote the voice of the patient in the daily operations of the system?
Yeah, I think our executives, when they attend an advisory council meeting, leave understanding what we're talking about. Because a lot of the work that we've talked about so far has been sort of the work to recruit or the work to recognize. But in a meeting, when somebody from the hospital comes in and says, I need your help on this, can you look at this? And they see that work, kind of the rubber meet the road, our executives are seeing that value. So I would say go to your PFACs.
So make sure that your executive teams have a chance not only to see the recommendations, but to see the level of dialogue.
Yeah.
I love that idea of having that systematic endorsement to move people from ideas or suggestions to endorsement is really a powerful one.
Yeah, it's been really fun. And I think it was meant to be really sort of a forcing function of ensuring that feedback is sought earlier than often our colleagues think.
I think that it's that ability to flip someone's mind. I think so many of us in healthcare have been influenced by anecdote. We have a one-off comment or a suggestion, and we tend to perhaps project what the solution will be. But to truly have a design partner who understands that the sky isn't the limit, that there are practical limitations to any changes we make, it helps us work through the nuances is very powerful. And once you've done that once, you can see how much time it saves, how much waste it saves, how many lost iterations we can avoid. And you can see why, whether it's in lean thinking or any kind of reliability design, or even as a baseline principle of human design, in healthcare, too often we've designed for patients, but not with them. And once your eyes are opened, that when we design with the customer, we get to value sooner. Yeah. It is a spark that clearly you've ignited, because that's why people are pulling them in. They don't have time to waste designing things that won't work for patients.
Yeah, and I think, as someone who oversees both the survey side of feedback and this team that is doing that direct touch with our advisory councils, when we all explain it as a team, we say there's kind of two arms. There's this performance improvement arm looking at the data as a whole and trends. Mm-hmm. We know this is true, and so we can recommend that. Or here's what your families are saying. And it's not always that the stories of our advisory council members or their ideas and advice are not somewhere also in that data, but here it can be bidirectional.
And I love that. I love that idea that without partners, we're getting a lot of feedback. How did we do? With the kind of partnership that you've created, we not only can hear how did we do, but also what would you like?
Right.
you and I have just come from a amazing learning session where we have been exploring the technology that could take patient and family input to the next level. How we not only can only rely on a Zoom meeting, but being able to talk to thousands or tens of thousands of patients at a time, crowdsourcing and prioritizing ideas, even letting patients videotape parts of their lives so that we could understand them differently. As you, with that massive experience in using patient and family advisors, thinks about what technology could do for us in the future, what are you most excited about?
Well, we are really excited to do crowdsourcing. That's something that Darcel and I talk a lot about. We've made do by having what we call a virtual council, although because so many of our meetings are virtual, people get confused. But we have a group of folks who at one time were perhaps in a formal PFAC or who were not able to commit the full time in general. So we've got a database of folks that we do pull on, and that serves as a bit of crowdsourcing, but thinking that we could go beyond to folks that haven't even heard of us and are not in our database, I think is where we get really excited.
I think the idea of not only getting ideas, but letting those ideas become prioritized so that we can feel like it's possible to be successful is really exciting. I'm excited. So much of our input from patients and families has been a burden on them. They have to disrupt their time. They have to disrupt their schedules. They are limited in their participation based on things like their ability to be flexible and commit to us. So for me, I'm excited about technology, including possibly some of the most important voices of people who aren't getting a voice because of limitations. And so I'm super excited about technology allowing us to include people who couldn't come to a meeting, who maybe don't feel comfortable talking up in groups.
Oh, yeah.
It can be so intimidating. And so I'm really giddy about how technology can take us to that next level.
Yeah. I think it's even just the ability. Often we preach, bring us your ideas early. But of course we get those emails that say, can you quickly get, PFAC's weigh in on this? And there's not a meeting until 3 weeks from now. And so, right now, bless their hearts, the team is, sending an email and then just like hoping to get the feedback back. So I think technology, even helping with those things that, of course, technology can do, that's not even necessarily out of the box technology, but it is going to make our lives facilitating their engagement much more seamless.
And you have brought up sort of the one hard sort of not downside, but if there's friction in collecting patient family voice, it's that translation function that someone has to go to the meeting, summarize the key findings without bringing our bias or editorial view, and then create something that could actually be digestible by those who weren't in the meeting. And when we look at some of the technology we have today to be able to capture words, to identify themes, and even bring out those most powerful quotes and have that happen with the push of a button, I have to say, as someone who has translated many a PFAC, I felt a huge weight taken off my shoulders. I can tell you the transcribe the PFAC to do on my CXO list was always something that was judging me after the meeting. And so I just from my own ease of scheduling, that feels very exciting to me.
Yeah. One thing that I don't think I have mentioned, but touches on a lot of the points that you've talked about, is the importance of also hiring folks also with those lived experiences. So, one of the reasons that I think Darcel is the right person to lead this work and does so well is, having been the parent of a medically complex kid, and taken, years to understand this system. And so, bringing that perspective helps with understanding what should come before a PFAC and where family voice really must be. And, I think that is really something you can't forget about when you're trying to do this work, is really making sure that you're actually also hiring in that way, and you are promoting, you are thinking about those leaders who have that lived experience.
Well, it's so funny. I was speaking to one of our colleagues earlier today, and they were talking about the fact that they have on their system PFAC, they have parents and then they have staff members, and there's a ratio, but they're having a hard time because so many of the parents who have come to them through their PFACs have actually become employees of the system.
Well, we have that too, and it's actually funny. I think this is on Darcel's wish list. We talked about this, is creating a PFAC for parents who are staff. So we do have the same ratio, and most of the folks who are staff members on our PFAC do also seek care at Children's National with their kids. But we've toyed with the idea of creating a PFAC group that is staff members who are parents.
Well, as we close, we have talked so much. This is going to be one of the most engaging conversations about where PFACs have been, where they're going, and how we can dream about them in the future. If you have 2 or 3 messages, the people who are listening to these are all the converted. They're all of us who support PFACs. If you want to challenge our thinking and say, what's one thing we need to start thinking about in supporting patient-family inclusion in our decisions, what are you going to challenge us to do?
I mean, making sure that the contributions of your patient and family advisory councils is heard by those throughout your organization. So, we report our work through the system board, the board of the hospital. Really important that people recognize this work and the contribution it makes. The other thing I would say is, really think about how are you connecting your different PFACs. That's something we've embarked on this past year, and I haven't talked about it with you yet, Chrissy, but we developed something called the collaborative, and it's not a hierarchical structure. The system level PFAC isn't at the top. They are one of the 8+ other FACs that we have, and that group with representatives from each PFAC meets, and they are learning what each other has done. So I think that's going to be a game changer as we do that more, is how can we, this is the work we do in the hospital side too. What can you learn from that unit that did this to succeed?
And that brings us to this idea of learning with and from each other. We've been challenged to think, how do we create the kinds of systems and thinkings that can really adapt, that we have agility, that we can learn in real time. I love that we're closing with that challenge to not only learn from our PFACs, but actually create a space where we're learning with one another.
Yeah. The families are there to, and the patients, I have to say, we have a youth council, so the patients and the families are there to help make us better, and they want to do that together. This is work they love, so we've loved bringing them all together in these settings.
A challenge that a patient family gave me this week, particularly in pediatric medicine, she said what they say in their family is that we can do hard things, but we can't do them alone. We're being called to continue to do hard things in healthcare. And the key for us is to not try to do them alone. Thank you so much for being with me.
Chris.
This was fantastic.
I love talking PFACs.
Yes.
That's a wrap. Thank you for joining us today, and special thanks to our guests for sharing their time and insights. Stay tuned for our next episode, which will be released soon. In the meantime, visit our website where you'll find more information on the human experience and a lot more.